Good morning. Not long ago, one of my dear friends was a patient at the Gosnell Memorial Hospice House in Scarborough, Maine. Despite her serious illness, her days were filled with visits from friends and families and many joyful moments. She was surrounded by her family when she died peacefully. In many cases, hospice care enables dying patients to remain in the comfort of their own homes, free from unnecessary pain, and surrounded by family and friends. The Gosnell Memorial Hospice House provides an alternative when care in the home is no longer possible or sufficient. It provides a comfortable, attractive, home-like setting for hospice patients and their families where they can receive patient-centered care. From pain and symptom management to psychological and spiritual support, and even to delivering longed-for scones to go with my friend's tea, the care at the Gosnell Memorial Hospice House is first-rate. Such compassionate, high-quality, and seamlessly coordinated care can make a tremendous difference for seriously ill patients, such as my friend and their families. Advances in medicine, public health, and technology are helping more and more of us live longer and healthier lives. But when medical treatment can no longer promise a continuation of life, patients and their families should not have to fear preventable pain, avoidable distress, or care that is not consistent with their values or needs. A majority of Americans say that they would prefer to die at home, yet most people die in the hospital. Fewer than 45% of Americans receive hospice care at home during their last stages of life, and nearly half of those receive hospice care in the final weeks or even days of their lives. Federal policies must support efforts to relieve suffering, respect personal choice, provide opportunities for people to find meaning and comfort during serious illness, and most important, remain in control of their own care. We know that hospice care can benefit both the patient and the family. So why aren't people accessing this service sooner? I'm concerned that this may be a result of a restriction in Medicare that requires beneficiaries to stop conventional curative care for their terminal diagnosis in order to elect hospice care. It is encouraging that CMS and organizations such as Blue Cross Blue Shield of Massachusetts are beginning to evaluate the benefits of allowing beneficiaries to receive curative and palliative care concurrently. As the Senate co-chair of the Congressional Task Force on Alzheimer's disease, I'm also particularly aware of the needs of Alzheimer's patients and their families. Although it is the fifth leading cause of death for seniors, Alzheimer's is not always viewed as a terminal illness, and too little attention is paid to the special end-of-life needs of Alzheimer's patients and their families. While strides are being made in improving care, people with dementia often die without the benefit of hospice care. Medicare's eligibility requirements for hospice can prevent some individuals with dementia from accessing quality care. Current regulations require a physician to certify that a patient entering hospice is likely to die within 6 months. It is difficult for physicians to determine with that kind of precision how long anyone with a terminal disease will live, and it is particularly challenging with a disease like dementia, which has an unpredictable trajectory. As a consequence, Alzheimer's patients who could benefit from the better pain control, fewer hospitalizations, and greater family satisfaction that hospice provides are under-enrolled in hospice care. Additionally, since hospice has traditionally been used for the care of patients with cancer, hospice staff aren't always sufficiently trained and prepared to meet the special needs of Alzheimer's patients and their caregivers. Today, we will explore ways to improve the quality and availability of care and discuss models of cares that are helping people with serious illnesses and their families. We are so fortunate to have an outstanding panel of witnesses, including a personal hero of mine, Dr. Atul Gawande, whose book, Being Mortal, has been a bestseller. But I thought I was going to have it right here to hold up. And this book, by the way, and my ownership of it, has an interesting journey. It first was read by Jay Rockefeller, who passed it on to Angus King, who passed it on to me, and I had my husband read it first, and then I got to read it. Now, Dr. Gawande is probably not happy about what that means for book sales, that there you go, I could hold that up, that there were so many readers. The iPad version. And I passed it on to my staff, whom I asked to bring it today. But we also have truly outstanding other witnesses, one of whom Senator Whitehouse will introduce, and I will introduce the other. But I want to thank all of them for being here today. Regrettably, one witness who was supposed to be here today is Dr. Catherine Pope. She was the medical director of that wonderful hospice house in southern Maine, but the thunderstorms caused her early morning plane from Maine to be canceled. I know that this issue is a personal passion for my colleague from Rhode Island, Senator Whitehouse, and I so appreciate his serving as the ranking member at today's hearing, and I now turn to him for his opening statement.